Thank you, Nico. Thank you, Clara, and thank you to the two Emanuele, Manos, inviting me here. I'm always very happy to be in Greece. For an Italian, it's easy. So now this is my disclosure, nothing to do with this presentation. And understanding the unstable shoulder at the end of this session, what can I add to everything that was already said? So I think it is just a wrap-up about the overview that you get from all the previous presenters and some personal perspective. I'm not adding many things, but maybe just a wrap-up of it. And since we are in Greece, I like to remember that we are in the nest of this kind of pathology. I mean, you see that the first reports are coming from this area, and especially, of course, the big master Hippocrates, who defined the relocation of the shoulder and even the first surgery. It was burning with the burning iron in the axilla. It was just pinching the skin and burning it, and it was the first surgery we were doing for this. So we are in the proper site for making this discussion. Then, shoulder instability, from where we should start, with the logical loss of anatomical position of the joint's end. It is the dislocation. Easy. But then, we started understanding that there is something in between. Some tricky condition, like the postural condition of the scapula that was shown by the German friend, or maybe some looseness, and many other conditions were adding to this basic dislocation of the glenohumeral joint. So let's go back quickly to the classification. If you look at the history of classification, you may understand the history of the knowledge and understanding of this condition. And if we know the history, we may not repeat some mistakes. So very quickly, we started with this many classification here. The Rockwood classification with traumatic, subluxation, atraumatic, voluntary, and it was probably 50 or 40 years ago. Then we moved much closer to our consideration, that is the Allen's classification, then the Madsen, traumatic, atraumatic, but not even covering all these conditions. And then Christian Gerber wrote a book on it. And if you go into all the classification he made, you probably spend your day, during the day, analyzing your patient just to focus what is wrong in that shoulder. So a little complicated, because he was trying to understand this. And probably, again, very clearly demonstrated before, the Stanmore one. That is traumatic structural, atraumatic structural, habitual structural. So you understand that thinking about it, we started thinking about a different condition of instability. So why it is that? Because the unstable shoulder is not just a dislocation, it is something that is related to the bony structure, the labrum, the capsule, the ligaments, the rotator cuff, the scapulothoracic muscles. And to my opinion, the shoulder is the most interactive joint in the human body, because it is a balance between static and dynamic factor responsible of the shoulder stability. And the malfunction of any or more than one of these elements may lead to overload or failure of the counterpart with the consequent glenohumeral instability. It is the most mobile joint with the sophisticated biomechanics. And when all the system is working, as you see here on the left, then you have a shoulder that is stable. However, you may reach this instability if even one or more of this structure is failing. So we need to think about it. We are not just watching to the labrum, to the bone, to the capsule, or to the scapula. We may look to one of them or some of them interacting and leading to some dysfunction of the joint. So let's stay open-minded when we face this condition. So what is shoulder instability today? For me, it is a clinical condition. It is not just something clinical condition, it is a syndrome. We have many elements there. We have the unstable joint, we have the pain, we have a dysfunction of the glenohumeral system in the 21 muscles that are acting there. So it is a clinical condition where the undesired, the patient, they don't want to do this, undesired translation of the humeral head over the glenoid compromises function and comfort of the shoulder. So it is a complex clinical syndrome around this system that is so sophisticated from a biomechanical and anatomical condition. This is why 13, 14 years ago, I did this even adding some more crazy ideas about the definition with this acquired instability in the overstressed shoulder, where very little things are there. Maybe the anterior superior labrum, maybe some looseness of the ligament, or even the AMSI, that very little is considered. In the lady after delivering a baby, we observed that. We have a changes in the collagen in the capsule because of the hormones, and they become even more loose. They keep the baby in their hand, and the shoulder becomes painful. But they are loose, hypermobile, and they will fix it. So imagine how crazy is the scenario that we may have around our shoulder. So understanding this complex stage is not easy, of course, but all the previous presenters said that we have some tests, and we can analyze our patient, listen to the history, because the history is leading us very much. So please, when you meet your patient, talk with him. What is your sport activity, your job or so, but never forget the postural analysis that with the pacemaker is becoming more and more important. And then Margarita spent a lot of time, but it was interesting describing all the imaging that is supporting us in understanding this for the soft tissue, for the bone. I'm not missing a lot of time on this, but you can have tear of the capsule, of the bone, of the labrum, and bone deficiency, all that stuff. Because the indication then becomes the final step of our itinerary in understanding the shoulder instability. Because there are pathology factors that are leading us to the indication for the treatment, can be surgical, and which kind of surgery will be later discussed by the next, so I'm raising the ball for that. So it can be surgery or conservative. So the type of lesion is important, but then never forget about the patient factors. Because age is important, very important, not very much mentioned, but this is something that we should keep under consideration. It is one of the major causes affecting our approach to the surgery, the kind of sport and the level of activity, even the sex, as already mentioned before. The number of dislocation and many other elements are facing this. So when you are analyzing your patient, you understand we have an unstable shoulder. You must understand that the unstable shoulder may arise for many possible causes, and the kind of these causes may guide you for choosing the proper indication. And there are many attempts to correlate both the pathological factors and the patient factors with many algorithms. And the first speaker today was mentioning the EASY score. Is this working? I believe that is giving us quite good indication, because this is the first version and then the second one from Pascal. And honestly, I checked this. This is almost 800 cases that my students reviewed in my cases. And what came out is that, yes, EASIS can give us some indication. Of course, not exactly so stiff as Pascal said, but you see that here we have an overall survival rate. Again, 5 years follow-up was the study. The survival was 85%, let's say. And when you have less than 3, the rate of success is very good. We have something like 6% of failure, that is reasonable. But when you go between 4 and 6, the rate of success is dropping down, and more than 6. So you see that we have a gray zone again in the indication that is not telling us exactly do the Latarjet to everyone, forget the Bankert arthroscopic repair or so. So again, let's stay open-minded. And my wrap-up is exactly this. When we are facing the glenohumeral instability in 2020, we must understand that instability is something that we know, is something that is not very stable. However, this instability is the same phase, the glenoid, the humerus, and the anatomy, but with different aspects. And we need to think with our brain with an open mind, because we need to understand the pathology, we need to understand the problem of the patient, and we need to understand what is the best for our patient, because then we have multiple treatment options in our hands. And this is the tough part, to make the proper choice. But you cannot make a proper choice if you don't have the proper perspective of the issue. So this is my end of this session, without making any special thing, but just stay open-minded when you face this condition that is instability, not just dislocation. and I hope to see you. This is the next meetings in Europe. In September 2020, we have the second European Society. 2021, my course, the Smile Shoulder Milan Interactive Live Experience, and 2022 in Europe, the World Congress. Thank you again for the invitation. Thank you.